So today I'm going to talk about some payer status effect on the survival of cancer patients. Of course, payer status effect also affect other diseases too. So since I'm working at a cancer center there, I will just talk about some topic in this area. So today, first I'm going to review some of the concept of cancer epidemiology. Majority of those here maybe you already know. And then introduce factors beyond treatment could also affect their survival too, such as payer status. After that, I will present some recent research to assess payer status effect on survival of cancer patient. What is epidemiology? Epidemiology is the study of distribution and determinant of a health-related state or events, such as disease or cancer. And the application of this study to the control of diseases and other health problems. Okay. So various methods can be used to carry out epidemiological investigations, such as surveillance and descriptive studies can be used to study the distribution. And analytic study can be used to study determinant. So what kind of study are descriptive? What kind of study are analytic? As we can see here, observational study, such as we call the descriptive studies, which include cross-sectional study or correlational study. We just do a survey at today to see how many faculty in this room, how many residents in this room. So just cross-sectional in this 2 minutes or 1 minute. So that's the snapshot of a cross-sectional study. Those called descriptive study. Analytic study, usually we analytic study, usually we use applied other methods. One of them is case control studies. Another is a cohort study, which we can also call prospective studies. For this study, we estimate some of odds ratio, attributed risk, relative risk, and of course, experimental studies sometimes in clinical trials, which are applied a lot in the medical field. We call clinical trials, which are on patient as a research subject. And some community trials, like vaccine trials, we implement HPV vaccine in Boulder compared to group in another city in Dallas. So since we don't have the cross contamination to assess community trial for HPV vaccine, can that really prevent cervical cancer or not? So that's a community trial, it's a large population. And then those things, those studies will look at the response rate, overall response, complete response, partial response, progress, stable disease, etc. Of course, we look at the hazard ratio for those studies. So since I'm a statistician, most statisticians deal with a variety of subject or topic. Usually we helping phrase the research questions. What do you really want to do? How do we answer that question? And then how do we design an experiment or study to answer your question? And then after that, you guys gather the data or can help you gather the data. Then we come to the stage how to summarize the finding and the result, analyze the data, draw a conclusion, and then communicate result to the officials or policymakers or some scientists. Of course, beyond those, I also help collaborate with some other investigator for grant application, and also I teach some statistics in graduate schools. And statistics deal with mainly three things. One is estimation. How do you estimate? How many patients are you seeing today, or are you seeing next year of today? We estimate or predict. And of course, we estimate the mean, standard deviation, incidence rate, prevalence rate, relative risk, etc., estimate. And then, of course, we want to estimate overall survival, median overall survival, progression-free survival. And then we perform a hypothesis testing. Your estimate is statistically significant, higher or different from other parameters. Then based on those, we make inferences. Are we going to reject your research question or accept the research question of no hypothesis or alternate hypothesis? So the statistical mainly deal with these three things. Of course, cancer statistics, usually we start with the simple things. One is estimate number of new cancer cases or deaths in the United States. For example, they predict in 2018 about 1.7 million new cancer cases. And of course, about 600,000 cancer cases diagnosed previously are going to die in 2018. Of course, they also, due to the advancement of the treatment, the cancer survival. So the survival of cancer in 2016, there are about 15 million cancer survivors. With this number in mind, if you are in medicine, if you are going to oncology, how many oncology trained over there? So you divide by 15 million for patient by the number of oncologists there. If each patient visits the clinic once, you can say the working load. You can predict, how many oncologists are they going to need, or whatever there. Then, of course, then in 2026, about 20 million cancer survivors you can predict. About Dr. Marin, it's about 400 oncologists trained per year, right? About only 400 newly fellow trained per year in the U.S. You can think about the numbers. Then, of course, beyond estimate the numbers, how many patients are there, then we usually say with the incidence rate and the prevalence rate. Just for you recall some incidence rate, many deal with the new cases in that period. And the prevalence rate, total number of cases are there. So if you can say prevalence, we can say cancer survivors are there in a year. And then new cases, new cancer diagnosed there. So incidence rate and the prevalence rate. Of course, we also have other things that adjust for the age, etc. Then measurement of association, we use some attribute risk, odds ratio, relative risk, or rate ratio, and the hazard ratio. So that's kind of estimate some of those association. Is one group significantly higher to another? Say this one analytic study to make sure one thing is determinant or not. Then, like a cancer incidence, just for example, new cancer cases in population at risk in that year, usually we use times 100,000. Since cancer cases is not that frequent, so we use 100,000 times the number here. Cancer mortality rate, same thing. The deaths due to cancer in population in a year, population at risk in a year. So that also times 100,000. Then I'm going over for the concept for now. I'll give you some recall. The survival rate is percent of people in study or treatment group who are still alive for a certain period of time after they were diagnosed, etc. Then survival rate often stayed as a 5-year survival rate. You don't have to use a 5 year. You can say 10 years, 7 years, 4 years, but as long as you mentioned. Then cancer survival rate, there are different kinds of cancer survival rate. Usually we talk about cancer survival rate express percent of patients alive at some point subsequent to the diagnosis of their cancer. There is one cause-specific survival rate. If someone diagnosed with lung cancer, their survival at certain years, then if they died due to lung cancer, then the survival rate is just 1 minus the percentage of death. That's the cancer-specific survival rate. Only died due to the cancer, lung cancer itself. The relative survival rate, sometimes for the large population study, it's very hard to say what the cause of death is due to the cancer itself or due to car, motor vehicle accident, or due to other heart problem or other things. That's relative survival rate just to use expected survival And the observed survival divided by expected survival is a very complicated process, but it's an alternative of the cause-specific survival. But in general, we use observed survival rate, so which is whatever survival, the cause of death due to any kind of reason, as long as they diagnose with cancer, we will say observed survival rate. Then cancer incidence rate, we can estimate this number here, we just talk about. Then lifetime of probability to develop cancer is 1 in 3, okay? Different cancer, the proportion are different, okay? Like this, pancreas, about 1 in 63. Then this one, the lifetime probability to develop cancer, for female is like a breast cancer 1 in 8. That's the number we have a specific formula at the end. If you want to see the formula, how can we get this number here? So if you want to see, I will show you the formula. And then as the new cancer cases, so in 2018, about 42% for male is about prostate, lung, and colorectal. About 800,000 here. Also 800,000 for female, but the breast was the first one. Okay, so these two are the similar between here. That's a new cancer case. That's talk about cancer epidemiology. We estimate the number there. Okay, then the mortality, similar here. Like these three, about 43%. Lung, prostate, colon. Okay, this one lung, breast, colon, about 47%. You can see the top mortality for this. Then talk about relative survival. You remember, I have overall survival, cause-specific survival, and observed survival. That's this one is for relative survival. It's all set in 1970s, about 49%. After 12 years, about 55. For now, about 69%. All set, no matter what kind of cancer. You can see some cancer improvement in leukemia treatment. So they increase from here only 9%, but here increase 20%. Then the 5-year relative survival by race. That means the race is also a factor. Okay, so all set Caucasian about 70 and 63%, about 7% difference. The reason underlying maybe genetics, maybe other lack of access to care or whatever there may cause. You can see the difference for this about 20%. This also 20% differences. So then we talk about health insurance statistics. This one, I just got the Census Bureau there. We can see in about 2013, 86% have any kind of cancer. This one probably 91%. I don't know why this turned to a value there. There are numbers somewhere 91% here. But you can see that's any kind of, the private insurance is over 2013 to 2017 due to Obamacare. You can see the Medicaid, more patients involved in Medicaid, enrolled, increase a few percent. So that's a percentage of insurance. Then cost of insurance, like a work itself, employer, sponsor coverage, we have to pay about, $1,500 in 1999. That's where I start work at here. At that time, I believe I pay around $2,800. This is family, for a family, you pay like $2,200 or $2,300 per month. That's $2,800. But this is a national survey, but some maybe less, some more. But for now, $5,700. I believe for family is about the number, $5,700. The increase about 3.7 times. But the premier, the employer paid about $6,000 at that time, but now about $18,000. The increase is 3.2 times. Look like a worker pay more compared to the employer. The increase is 3.7 times, 3.2 times. Then here, different kind of healthcare provider only accept certain kind of insured patient. You can see this, any new patient about 97%, but primary care physician only Medicare patient about 65%. So if you are Medicaid, you have a lack of access to certain care. Okay. Then, so how about this insurance? does it has really an effect on the patient's survival or not? Then, this in 2009, I read a paper in Cancer. So the guy from, at that time, he worked at ACS, American Cancer Society. So he used some data to analyze, use a national cancer database. You can see privately insured, their survival is much better than Medicaid and uninsured. This is only 5-year survival. Since at that time, National Cancer Database, they only provide certain data, follow-up for 5 years. So they use 5-year survival. This all give me some triggers. In 2014, another guy looked at the insurance effect on colon cancer. 2003 and 2010, you can see 5-year survival. The Medicaid is still here. The private, still much better. So that's national data. Then, so that's the specific for the multivariate analysis here. You can see Medicaid patient increased risk of dying by 44% compared to private insurance. So if their insurance are private, their risk of dying is 1, but the Medicaid increased 44%. That's at that time for this. So actually, I look back at all cancer center data at all. We are a charity hospital. About 1987 to 2006, there are about 987. Actually, have more patients, but some patients do not have a certain number of variables. I only have about 1,000 patients in this study. So after this, initially, as we already know, the stage of cancer really, has an effect on their survival. You can say stage 1, this is for breast cancer patient. Stage 1, they much better. Stage 2 here, 3 and 4. So the later the stage, the worse the survival. So the stage has an effect on the survival. Then we look at the insured. You say, as an institution, charity hospital, you supposedly treat the patient equally, since they all come to in the same institution. That's the supposedly. But actually, you look at the insured patient here. These are univariate analysis. Okay, they have doing much better. Medicaid here and uninsured here. Okay, that's in this hospital. So with this, I submit a publication. At that time, Dr. Glass is still here. We have a publication. Since they use a short communication there, we publish this commercial insurance. For the univariate analysis, we can say uninsured increased risk of dying almost 4-fold, 3.8 times. But Medicaid about 2.3 times compared to insured. That's in univariate analysis. But some underinsured may be diagnosed at later stage. So in a multivariate analysis, after adjust for the race, stage, age, and the BMI and the zip code income, uninsured still increase risk almost 3 times. So look like uninsured patient are survival worse than the insured patient. So why the patient is supposed to treat here equally? So that have something, maybe due to some other reason I will discuss later on in the end there. So in that case, I thought maybe only 1,000 patients is not enough. So I start to apply for the National Cancer Database. Since I have the 2009, that guy triggered me to say, oh, insurance affect, they use that data. Let me do it something. So 2015, I applied a National Cancer Database. Still looking at breast cancer, almost 1 million cases. Okay, for 1 million cases, then you can see uninsured and private. This added together is 100%. This added is 100%. You say for uninsured stage 1 diagnosis only 30%, but you say insured or private almost 50% diagnosed at the early stage. So that gives you some thought. Oh, if you have insurance, you may detect early at the early stage, but for the later stage, I can say stage 3 or 4, about 28% for uninsured, only 13% for here. You can also say Medicaid 28%. You say that Medicaid also stage 1, only 30%. So it's kind of like a stage associated with the payer status. And then, of course, the survivorship not only affected by stage, so we adjust for the age, race, education, and Charlson comorbidity, and then we still look at the private insurance. You say 36% are less likely to die compared to uninsured. So the private insurance are actually doing much better. Okay, but you can see Medicaid is even though increased 11% compared to uninsured, appears Medicaid still doing worse than the patient without insurance. One of the reasons may be due to the person without insurance, they may not qualify for Medicaid, or they have adequate money, but they don't want to buy, or whatever reason, it's unclear. So we can see that these are detailed variable adjusted in the analysis. You can see this adjusted overall survival. So when I look at the insurance side effect, this one survival adjust for the age, race, whatever I listed in the previous table. You can see here the private still doing much better compared to the Medicaid here. Okay, so it says something. Then, of course, Charlson comorbidity. This is Charlson index. If they diagnose with breast cancer, at the same time they have diabetes, that kind of score 1. Okay, if they have leukemia beyond breast cancer, the score is 6. But anyway, this one we call score of 0, 1, 2, and 9 is a missing unknown score. Okay, so we can say the Charlson comorbidity without comorbidity, you only have cancer itself, you survive better than if you also have other diseases. Further, that's in breast cancer. We also look at AML. In 2016, we look at about 34,000 patients. Okay, with this patient, we can still say, for private insurance, Medicare insurance increase the risk of dying for 20%. That's for AML. Okay, then of course we look at does the chemo plus stem cell transplant has some meaningful improvement or not. We can say if there's no chemo, no stem cell, they may receive other supportive care or other care, but this no chemo, no stem cell transplant compared to this chemotherapy only and chemo plus stem cell transplant, appears that chemo still improve patient survival beyond the previous factor for AML. Further, we look at the radiation effect in the breast cancer patient for pathological nodes 2 or 3. They have lymph nodes 4 up and up. For this patient, we look at the radiation effect. In this, we also assess the payer status effect. We can see for private insurance, Medicaid increase risk of dying about 30%. As remember, this is only for pathological nodes 2 and 4. The lymph nodes are positive for 4 and above. They are all very narrow patients. They all receive postmastectomy surgery, and then get the radiation. Then we look at their direct adjusted survival by this different kind of treatment. You can see they receive radiation, hormone, chemo. Their survival is much better than this one here, but may not have some difference. I have an evaluation next slide there, but this is a full adjustment for other effect. We look at the result here. Then here we assess the radiation effect. You see radiation versus no radiation, no hormone, no chemo. You can see the hazard ratio increase about 3%, but it's not statistically significant. Further, radiation hormone versus hormone, that means still we look at the radiation effect. So the risk reduced about 35%, but statistically it's not significant. Further, radiation plus chemo versus chemo, the risk reduced 26%. You look at it, still not significant. Look at this, the risk reduced, still not significant. Appears radiation did not add too much effect on the patient they receive mastectomy. Okay, so but whether or not the clinicians or radiologists they want to think about before they put more radiation on this kind of patient, they have to look at. Of course, this is only one study, even though it's a million cases, but for radiologists, they may not adapt this theory here. So further, we look at for those patients, by the lymph nodes. They have less lymph nodes, the 5-year overall survival better than the more lymph nodes. Similarly, for ER, PR, negative or positive, the breast cancer, their ER and PR, those receptor positive, negative, really response or not to the treatment. You can see the positive have better survival, the negative has a little worse, since they don't respond to the treatment. So that's the reason right now they call precision medicine or targeted medicine. If they are ER, PR negative, you don't give those treatment, focus on the ER, PR negative patient. Further, for all the previous studies are retrospective studies. We have a patient, the number already there, we look back forward. But, for example, all the breast cancer patients, when they were diagnosed, we look at the insurance status. Later on, 10 or 20 years later on, we see their survivorship. But optimally, it's randomized clinical trials can balance certain factors. And then we randomize all those, for example, private insurance patient, Medicaid patient, to one of a treatment group, like intervention new or traditional care. Then we follow up. So this one we can have a accurate estimation of payer status effect. Because it's hard to say, if you have private insurance, let's randomize to here or randomize to there. But instead, we have in statistics, we use a propensity score method matching to simulate a study from the retrospective database to say, can we balance a lot of factors to assess the payer status effect. So like this, I have about colon cancer patient, about 60,000, and then all patients receive surgery. Only variable I include is whether or not receive chemo. If they for other therapy were excluded, the payer status and other factors were adjusted in this analysis. So try to simulate how are we going to do those. Propensity score is calculated, say, for example, use the payer status as a private, non-private, or Medicaid as an outcome variable. To predict with these certain variables, you are assigned in one of the group. If you are really interested, we can talk about this later on. This is one of the technique to do the simulation. Then, like this, before propensity score matching, we can observe median overall survival for the Medicaid patient. It's about 8.some years. But for private, you can say about 12 years. Just simply do nothing, we observe the payer status has an effect on the survival of this patient, colon cancer patient. But maybe due to other factors, you say, before matching, I have about 60,000 colon cancer patient and with private insurance, and then Medicaid has 6,000. So you can see the balance between these variables, except this one, they are imbalanced. For example, this has a 48% female, but this is 33% female. 52% female, Medicaid patient. That's for female. Then, for the comorbidity, this one 22%, if they have insurance, comorbidity are 22%, but the Medicaid 30% comorbidity. But after propensity matching, you can see every factor are balanced. If you can see there are 1, 2, 3, and 4 ones. So when I do the matching exactly, they have to be male, match with male for the Medicaid private. Everything you see the one here, the exact match. If they're African American, we match another African American, etc. So they are very balanced. So that means in randomized clinical trials, a lot of factors you observed are very balanced. The only difference is they receive different treatment. At the end, there is a difference. That means the difference majority of the time is due to the treatment. This is similarly analogy we use here. So after matching, you still see the similar trend. Okay, so for Medicaid, 8.8 years of median overall survival. This one 12.82 years. You see this one after matched. Okay, so about 4 years of difference. If you have a private, your survival is 4 years longer than the Medicaid. That's for colon cancer. Then those are just without adjust other factor. That's univariate. After adjust other factor, you still can see the insurance of Medicaid increase risk of dying by 50%. But before matching, the risk of 54%. So that means maybe due to other factors. But that's again, so after matching, so the payer status is still significant. Of course, the chemotherapy also significant. If without chemo, the risk of dying increased by 90% compared to the receive chemotherapy. Then, the possible reason for the insurance effect, one of those may be due to the later stage of diagnosis. If they have the uninsured, if they are uninsured or underinsured or Medicaid, they may be in part explained by the lower access or follow-up, or utilization of cancer screening. They can't go to the clinic on time, or they don't have transportation, etc. Later stage diagnosis may be associated with lack of follow-up also. Then you say this one just is uninsured. This slide I showed before. They diagnose stage 1 30%, but private is 47%. So if you have insurance, you are diagnosed with early stage. Then see another way. This is for non-small cell lung cancer. Since I work with 10 kinds of cancer, non-small cell lung cancer, you can say uninsured, the stage 4 about 56% when they were diagnosed, but private only 43. Okay, so this is for non-small cell lung cancer that when they diagnose it. So you can say the stage of diagnosis are associated with the insurance. So time to initiation of hormonal therapy for breast cancer. This is from 987 patients of breast cancer at the cancer center here. I did a briefly review only 400 of 900 patients. You can see this by the uninsured, there are not much difference here for the time to initiate hormonal therapy. But here appears uninsured take a little bit longer for months, but still statistically it's not significant. This I didn't do a detailed analysis for this. Further, there's a mean length of hormonal therapy. Once they start hormonal therapy, how long they receive those appears also statistically different here, but the uninsured and the insured are similar, but Medicaid are shorter. So you think about that Medicaid has something, maybe due to whatever reason they do not receive adequate treatment. Then in general, the underinsured may be lead to later stage of diagnosis and then the shorter survival. Underinsured, lower access to care or quality care, they may shorten their survival. Of course, a lot of other factors also associated with the survival. The limitation of the retrospective study, also selection bias, etc., recall bias, and etc. Also, the change of insurance status over time are not documented. Those are insurance payer status only at diagnosis. Maybe 5 years later, they find a job, promoted to the chancellor. Of course, you get insurance somehow. But then whatever, the insurance status over time are not documented. The crucial treatment variable, somewhat like a chemotherapy, just yes, no. What kind of chemo they receive, how long they receive, etc. So that's a limitation. Also have other limitation. So, those research traditional model, we are doing the payer status, hospital type, treatment, stage, etc. affect their survival. But they also have other models to investigate. You say the payer status affect their survival maybe due to the chemotherapy. They receive adequate or non-adequate chemotherapy through the chemotherapy affect their survival. We call them mediation analysis. But this is just a very simple model. You may think about the overall survival is affected by their age, race, of course by treatment, and of palliative care. That's Dr. Marine's specialty. And then the treatment itself, we already say maybe due to the payer status, social payer status, maybe stage. The different stage of cancer receive different kind of treatment. Of course, like breast cancer, the ERPR status also affect their treatment choice. But for stage, they associate the early detection or not. This early detection, whether or not the community resource, etc. So the treatment also, time to initial treatment also associated here. Also adherence to cancer treatment, also some comorbidity here, etc. So it's now that simple to say a payer status affects the survival, but it's a lot of factors that need to be investigated. So in summary, I have reviewed some concept of epidemiology and introduced factors that could affect cancer patient survival, present some research, limited research for this is my studies and others. Payer status indeed did affect survival patient, but the underlying mechanism need further investigate. So I acknowledge some of faculty over there work with some of cancers and appreciate your attending. If you have any questions, just let me know.